the human neck. This small space is packed with major arteries carrying blood to the brain, massive veins draining the head, critical nerves controlling everything from breathing to speech.
And of course, the pathways for air and food, all crucial for just, moment-to-moment survival.
So we really need to understand its layered organization, which, as the sources suggest, isn't just vital for simple movement, but is fundamentally for clinical practice. It guides surgeons and helps predict the spread of infections.
If we connect this to the bigger picture, the sheer efficiency and organization of the neck's structures, especially the way the deep fascia create these firewalls and the way muscles divide the space into triangles, it's anything but arbitrary.
It's design.
It's intelligent design, really.
Yeah.
This system provides predictable landmarks for surgeons, allowing precise access with minimum damage to vital neighboring structures. And maybe even more critically, these layers dictate where infection and metastatic cells travel.
So understanding this structural map is crucial for predicting or containing pathology.
Absolutely, which is why we're going to break it down layer by deliberate layer, starting right at the surface and moving inward to the visceral core.
That structural map analogy works perfectly. So let's start laying the groundwork literally with the outermost layer.
Let's do it.
Starting at the very top, we have the skin, the subcutaneous tissue, and the superficial lymphatic drainage. Even just the skin here has important considerations, doesn't it? Particularly for anyone making an incision.
Oh, absolutely. The text highlights the tension lines, better known as Langer lines,
Right.
and the orientation of collagen fibers in the skin creates these lines of tension. So when an incision is made parallel to these Langer lines, the wound edges naturally sort of approximate. They come together.
Which leads to better healing and less scarring.
Minimal postoperative scarring. Essentially, you're aligning your cut with the natural direction of the skin's tension, which aids the body's repair process. It leads to a much better cosmetic and functional result.
And in the neck, which way do they run?
Generally, they run transversely, horizontally, which is why horizontal incisions are almost always preferred unless, the underlying pathology absolutely dictates otherwise.
Okay, so moving a bit deeper into the superficial fascia, we hit the superficial vasculature. The source mentions that the blood supply to the skin and deep fascia is derived from multiple arteries forming these subcutaneous and subdermal plexuses.
Yes, which suggests a very rich, highly redundant blood supply.
So what key vessels are contributing to this superficial meshwork?
It is an incredibly robust system, and it's what allows for some really complex surgical skin flaps in this area. The arterial supply to the anterior cervical skin is primarily maintained by the superior thyroid artery. That's the first major branch off the external carotid.
Okay.
And also by branches that originate from the subclavian artery, specifically the thyrocervical trunk.
On the back of the neck.
The posterior skin gets its supply from branches of the external carotid artery as well, notably the occipital artery and its upper anterior branches. Plus, the skin over the lateral neck gets supply from the subclavian, the external carotid, and the transverse cervical arteries.
So it's really overlapping supply.
It's an extensive overlapping supply which ensures tissue viability, even if one of the major feeder vessels is compromised. It's built for resilience.
What about the venous drainage within these superficial layers?
Yeah.
We always hear that veins are far more variable than arteries.
And that variability is a key characteristic here. The venous supply within the skin of the neck facilitates the design of what are called random pattern flaps, those based solely on dermal and subdermal plexuses.
Okay, so you don't need to know the exact location of a major vessel for the flap to survive.
Exactly. They can often be made larger in this region than elsewhere in the body because of this rich drainage network. The superficial veins ultimately drain into the three major jugular veins, the internal, external, and anterior jugulars.
So they mirror the arteries just more variably.
They do. Specifically, the venous drainage of that superficial layer is supported by branches of the superior thyroid, anterior jugular, and the external jugular veins. They mirror the arterial supply in many ways, but yeah, their specific paths are just less predictable.
Now on to the lymphatic system, which in the neck is less a simple drainage system and more of a vital map for disease.
A roadmap, absolutely. Infections or metastatic disease spread along these predetermined routes, and knowing the pathways is essential for any clinician.
So where does all this superficial lymph drain?
The superficial lymphatic drainage in the head and neck is highly organized. Lymph from the skin and superficial fascia converges, and it tends to follow the venous lines, heading towards the terminal group located down in the supraclavicular region.
And from there?
It ultimately drains into the internal jugular or subclavian vein to get back into the circulation.
And more specifically, if we're looking at different regions of the neck skin,
Well, lymph from the superior region of the neck drains first to the submandibular and submental groups of nodes, which are themselves superficial. Lymph from the posterior cervical skin, however, typically flows towards the deep lymph nodes of the posterior triangle.
following a nerve, I believe.
It does. It often tracks right along the path of the accessory nerve, cranial nerve 11. But crucially, the lymph nodes from the skin of the entire neck drain via the superficial cervical nodes.
Which run in a chain along which vein?
Along the external jugular vein, the EJV. These superficial nodes act as collection points, and they receive drainage from other, more proximal nodes like the parotid, the retroauricular, and the infrahyoid, protracheal, and prothyroid groups.
So if you feel an enlarged, tender lymph node, it's like seeing a road sign telling you exactly where the source of the infection or disease is coming from, even if it's miles away up in the scalp or face.
That's a perfect analogy, and the source explicitly mentions the supreme importance of the supraclavicular lymph nodes, often referred to as level V nodes.
Why are they so important?
Because they receive drainage from both superficial and much deeper regions of the head and neck. And because of this, they frequently act as the first sentinel nodes for diseases originating outside the head and neck entirely.
Like what?
Like gastric or lung cancers. If you see hard, non-tender nodes in that supraclavicular area, what we call Virchow's node, the investigation immediately broadens way beyond the neck itself. That lymphatic drainage pattern is perhaps the most important clinical nugget of this whole superficial layer.
It provides the pathologist and the surgeon with a crystal ball for predicting disease spread.
It really does.
Okay, moving slightly deeper now, past the superficial muscles and vessels, we reach one of the neck's most distinctive and structurally essential components. The hyoid bone.
Ah, yes, the floating anchor.
The unique U-shaped bone at the C3 level. Famous for not articulating with any other bone, it's suspended entirely by this complex network of muscles and ligaments.
Correct. And we call it the floating anchor for a reason. It is absolutely critical. It acts as the central fulcrum for the complex movements required for speech, swallowing, deglutition, and controlling the base of the tongue.
How is it suspended?
Structurally, it's suspended by the stylohyoid ligaments, and it forms the foundation for the larynx below it and the tongue above it. Its importance lies not in its size, but in the sheer volume of muscle attachments it provides, which coordinate those essential functions.
So it's an elevator for the tongue and a depressor for the larynx. Let's run through its parts and their attachments, because listing these details really highlights just how much is tethered to this one floating structure. First, the body.
The body is the central, irregular, elongated, and somewhat quadrilateral part. We describe its shape precisely. Its anterior surface is convex and extends posteriorly and slightly downward, while the posterior surface is concave. It has this gentle curve.
And there's a ridge on it.
A vertical median ridge often bisects the upper part of the body, creating very clear attachment points. The muscles attaching directly to the body are all involved in the strap system or the floor of the mouth. The mylohyoid, geniohyoid, sternohyoid, and omohyoid muscles.
But it anchors other muscles too, right? Indirectly.
It does. It anchors muscles indirectly via fascial connections, like the hyoglossus muscle and the intermediate tendon of the digastric. Both are linked through ligaments or the thyrohyoid membrane. This makes the body the structural core for both the suprahyoid, the elevating, and infrahyoid, the depressing systems.
Then we move to the projections, starting with the greater cornua.
The greater cornua are the longer, thinner projections that extend posteriorly from the lateral ends of the body. They usually surpass the rest of the body in size, and they curve slightly upward.
And these are connected how?
Initially, they're connected to the body by fibrocartilage, but they often fuse completely with the body in later life. Their tips are expanded and often palpable, which makes them a really useful clinical landmark when you're examining the neck.
And what's attached to these longer projections? What's their purpose?
They stabilize the bone against opposing muscle forces. Key attachments here include the thyrohyoid membrane, which connects the hyoid to the thyroid cartilage below.
Right.
The middle pharyngeal constrictor, which is a key muscle for swallowing. The hypoglossus muscle, and the omohyoid and digastric muscles again. The fact that the pharyngeal constrictor attaches here really highlights the hyoid's involvement in shaping the upper pharynx for bolus passage.
And finally, the smallest projections, the lesser cornua.
These are small, conical projections located right at the junction of the body and the greater cornua. Like the greater cornua, they start out connected by ligaments or cartilage, but their fusion in later life is far more variable and inconsistent.
So it's attached to them.
The source highlights two specific key attachments here: the stylohyoid ligaments and the superior part of the thyrohyoid membrane. That stylohyoid ligament is key to the hyoid's floating nature because it suspends it from the styloid process of the skull.
It's amazing that a bone that floats and is so central to functions we use every single second still has such a complex developmental timeline. Tell us more about the ossification process, particularly how long it takes.
The hyoid bone has a fascinating multi-arch embryological origin. It derives from both the second and third pharyngeal arches, which explains the complexity of its adult structure and the innervation patterns of the muscles that attach to it, which we'll get into later.
And the timeline.
The ossification timeline is exceptionally protracted. Ossification typically begins prenatally in the body and greater cornua. However, the complete fusion of the greater cornua to the body usually occurs quite late. We're talking between 42 and 50 years of age, postnatally.
Wait, 42 to 50 years. That is unusually late for a major skeletal structure to fully fuse. Is there a reason for this forensic detail?
Oh, yes. That timeline is incredibly forensically relevant. In cases of manual strangulation, the hyoid bone is frequently fractured. Knowing the fusion status helps forensic experts estimate age and potentially differentiate premortem versus postmortem fractures. If the greater cornua hasn't fused to the body, a fracture is far less likely to occur from that kind of blunt force.
And the lesser cornua?
Their fusion is even more variable. They often remain cartilaginous even into advanced old age, which highlights the persistent flexibility needed in this mobile nexus.
That context transforms the anatomical detail from a simple measurement into a critical piece of forensic and developmental knowledge. Incredible.
It really is.
Now we move to how anatomists and surgeons impose order on this packed region, the triangles of the neck. This concept transforms the neck from a shapeless cylinder into a structured, reliable map.
Absolutely. Think of this as the body providing its own natural GPS coordinates. The neck is structurally divided into an anterior and a posterior quadrilateral area, generally limited superiorly by the border of the mandible and inferiorly by the clavicle and sternum.
And then the big muscle cuts through it.
Right. The massive, obliquely running sternocleidomastoid muscle, the SCM, then subdivides these areas into the two major triangles, which are then further split into subtriangles.
And this is all about landmarks.
It's all about providing necessary, unchanging landmarks for surgical access, for clinical examination, and for precisely locating vascular and nervous pathology. It's the map.
Let's start with the anterior triangle, which is the main staging ground for procedures involving the airway, feeding tube placement, and major vascular access. What are its boundaries?
The anterior triangle is defined by three specific borders: the median line of the neck anteriorly, the anterior border of the sternocleidomastoid muscle laterally, and the inferior border of the mandible superiorly.
What about its roof and floor?
Its roof is formed by the superficial fascia, and its floor is this mosaic created by deep muscles like the mylohyoid, the hyoglossus, and the inferior pharyngeal constrictor.
And the critical structures inside.
The crucial structures contained within the anterior triangle are the major neurovascular bundle. So, the internal jugular vein, the carotid vessels, and the vagus nerve, along with the most important lymph node groups, specifically levels 1, 2, 3, and 4.
Okay, so within the anterior triangle, we have 4 subdivisions. We can group these functionally. First, let's look at the area related to the floor of the mouth and the salivary glands, the digastric triangle, often called the submandibular triangle.
The digastric triangle is bordered superiorly by the inferior border of the mandible and inferiorly by the two distinct bellies of the digastric muscle, the anterior and posterior.
And its floor and roof.
The roof is formed by the skin, superficial fascia, and the ubiquitous platysma muscle. The floor is composed of the mylohyoid and hyoglossus muscles.
So what are the primary bulky contents of this triangle? What's filling up that space?
The primary content is the submandibular gland, a massive salivary gland that partially wraps around the posterior border of the mylohyoid muscle. It really covers the floor and is partially superficial.
And the vessel.
In terms of vessels, this is where the facial artery takes a key path. It passes superficially to the gland, often looping in this predictable S shape before it crosses the inferior border of the mandible to enter the face. The facial vein usually passes right over the gland.
And which nerves and lymph nodes are housed here? What does their presence tell us?
Key nerve structures traveling deep in this region include parts of the hypoglossal nerve, cranial nerve 12, which controls the tongue muscles, and the mylohyoid nerve, which is a branch of the trigeminal V3.
And the lymph nodes.
The lymphatic contents are the submandibular lymph nodes, level I nodes, which receive drainage from the central face, the teeth, the tongue, and the floor of the mouth. So if these nodes are enlarged, the source of infection or cancer is generally oral or facial.
Okay, and there's a major artery deep here, too.
Yes, knowing the exact course of the external carotid artery, which loops deep to the digastric muscle and the submandibular gland before giving off its branches, is essential for vascular control in this whole area.
Next, the smallest of the group, located right under the chin, the segmental triangle.
This is a single, unpaired triangle located inferior to the chin. It's bounded by the hyoid bone inferiorly and the two anterior bellies of the digastric muscle laterally.
The floor is formed by?
The floor is formed by the two mylohyoid muscles and their intervening raphe. Its contents are pretty minimal compared to the others, primarily the segmental lymph nodes and small veins that eventually drain into the anterior jugular vein.
And their drainage pattern tells us?
It drains the central lower lip and the chin, so these nodes are often checked for disease originating from the floor of the mouth.
Now, the muscular triangle is where we find the structures involved in airway and swallowing function. The visceral compartment we'll detail later.
Right. This triangle is bounded by the midline of the neck, the anterior border of the SCM, and the superior belly of the omohyoid muscle.
And its contents?
The primary contents are the stabilizing infrahyoid strap muscles, the sternohyoid, sternothyroid, omohyoid, and thyrohyoid. They act like a corset to depress the hyoid and larynx after swallowing.
And deeper still.
Deeper structures found here include the thyroid gland, the adjacent parathyroid glands, the trachea, and the esophagus. This is the area of surgical access for a tracheostomy or any thyroid procedure.
And finally, the carotid triangle. If there is one subdivision of the neck that is the most critical for understanding neurovascular anatomy, this has to be it.
This is the critical crossroads. This is where life-sustaining structures are at their most superficial and most accessible.
What are its boundaries?
It's defined by the superior belly of the omohyoid, the posterior belly of the digastric, and the sternocleidomastoid muscle. Clinically, the bifurcation of the common carotid artery often creates this small, visible, triangular depression right at its center, making it a very reliable landmark.
What are the key contents within this small but absolutely vital triangle?
You find the entire neurovascular bundle here. The common carotid artery, the CCA, which bifurcates here into the internal and external carotid arteries.
And the vein and nerve.
The internal jugular vein, the IJV, and the vagus nerve, cranial nerve 10, all contained within the carotid sheath. We also find the crucial sensory structures here. The carotid sinus, which is the baroreceptor, and the carotid body, the chemoreceptor.
So much in such a small space.
And there's more. Parts of the hypoglossal nerve, the accessory nerve, and the major early branches of the external carotid artery, specifically the superior thyroid, lingual, and facial arteries, they all emerge or pass through here.
And what about lymph nodes?
Finally, the deep cervical lymph nodes, specifically levels 3 and 4, are found immediately adjacent to the carotid sheath. These nodes receive deep drainage from the larynx and pharynx, meaning they are frequently involved in head and neck cancers. It's a packed, high-stakes piece of real estate.
Shifting our focus now to the back and side of the neck, away from the midline viscera, we examine the posterior triangle. This region is critical for understanding shoulder movement and the origin of the nerves that supply the upper limb.
The posterior triangle is delimited or, defined by the posterior edge of the SCM, the superior edge of the trapezius muscle, and the middle third of the clavicle inferiorly.
And its floor isn't flat, right?
Not at all. The floor of this triangle is a muscular ramp formed by several muscles. The splenius capitis, levator scapulae, and the anterior, middle, and posterior scalene muscles. This complex muscular floor highlights why this region is so crucial for both shoulder and deep neck movement, as well as providing pathways for major neurovascular structures.
And like the anterior side, the posterior triangle is subdivided by the inferior belly of the omohyoid.
It is. This creates the occipital triangle above and the supraclavicular triangle below.
Let's look at the upper, larger subdivision first, the occipital triangle.
The occipital triangle is bounded by the SCM, the trapezius, and the omohyoid. Its floor, as we just mentioned, is the splenius capitis, levator scapulae, and scalenus medius.
And what's the most important structure crossing that floor?
The most important content crossing the floor is the accessory nerve, cranial nerve 11. It runs obliquely or transversely across the triangle, often very superficially, before it disappears into the trapezius to provide its motor innervation.
Which makes it very vulnerable.
Highly vulnerable to injury during lymph node dissection in this area. Other contents include the occipital artery, which courses superiorly, superficial cervical arteries and veins, and the deep cervical lymph nodes of level V.
The lower portion, the supraclavicular triangle, sometimes called the subclavian triangle, is smaller, but contains structures of immense vascular and neurological significance.
It is. It's bounded by the SCM, the clavicle, and the omohyoid. And because of its relationship to the clavicle, its size changes dramatically depending on neck position. It almost disappears when the shoulder is elevated.
And what's inside?
This triangle contains the lower part of the internal jugular vein, the terminal part of the subclavian vessels, both artery and vein, the trunks of the brachial plexus, and the supraclavicular lymph nodes.
So this is where we run into a major vulnerability point, that confined passage for the vessels and the nerve trunks heading into the arm.
Precisely. This is arguably the most common site of major neurovascular compression. The subclavian artery arches powerfully over the first rib. And critically, the massive trunks of the brachial plexus pass directly with the subclavian artery through the small interval between the anterior and middle scalene muscles.
This is a very tight passage.
It's an incredibly tight passage. This means that any hypertrophy, any spasm or trauma affecting the scalene muscles or an extra cervical rib can compress these neurovascular structures, leading directly to symptoms of thoracic outlet syndrome or TOS,
which presents as
numbness, weakness, and altered circulation in the arm. It's a classic compression syndrome.
Furthermore, the proximity of the subclavian vein, which runs just anterior to the scalenus anterior muscle, makes this triangle a common site for central venous cannulation and thus a high-risk area.
Yes. And just to add another layer of complexity, on the left side, the thoracic duct, which drains lymph from the entire lower body, often hooks over the subclavian artery and drains into the junction of the internal jugular and subclavian veins right here.
So any procedure in the root of the neck has a huge number of potential complications.
It adds another layer of complexity and risk to any procedure performed there. Absolutely.
To truly understand how structures are protected, stabilized, or how pathology spreads rapidly through the neck, we have to discuss the fascial layers. We shouldn't think of these as just connective tissue. They're rigid architectural boundaries, anatomical firewalls.
That analogy is perfect. The deep cervical fascia is organized into three major distinct layers: the investing, the pretracheal, and the deep cervical or prevertebral fascia, plus the carotid sheath.
And this compartmentalization is the body's defense mechanism.
It is. It confines hemorrhage, it directs the spread of infection along predictable pathways, and it defines the planes that surgeons use to operate safely. When an infection breaches one fascial layer, we immediately know where it's going next.
Let's start with the investing layer, the most superficial of the deep fascia. What does it cover, and how does it define our landmarks?
The investing layer is the most external of the deep cervical fasciae, and it completely encircles the entire neck. It functions like a tight external sock. And crucially, it splits to enclose the two major superficial muscles we've discussed, the sternocleidomastoid and the trapezius.
So it gives these muscles their definition and their sheath. Where does it anchor itself?
Superiorly, it attaches to the mandible, the mastoid process, and the superior nuchal line of the skull. Inferiorly, it attaches firmly to the clavicle, the sternum, and the acromion of the scapula.
And it encloses glands too, right?
It does. It also splits superiorly to enclose two major glands, the submandibular and the parotid glands. And the clinical significance here is huge.
Why is that?
Because this layer is tough and relatively inelastic. Infections originating in these glands like mumps in the parotid or silodonitis in the submandibular gland are often contained by this fibrous capsule. This leads to intense pain and a highly palpable, tense swelling that just can't expand easily.
Okay, next, the pretracheal layer. This must be intimately associated with the vital visceral structures we mentioned earlier, the airway and the food path.
It is the visceral envelope. The pretracheal layer extends inferiorly from the hyoid bone, and it's often described as having two functional parts. There's a muscular portion enclosing the infraoid strap muscles anteriorly,
Okay.
and a deeper visceral portion, often called the buccopharyngeal fascia, that encloses the thyroid gland, the trachea, and the esophagus.
And this layer has a significant and potentially hazardous attachment point at its base, correct?
It does. Inferiorly, the pretracheal fascia descends all the way into the chest and blends seamlessly with the fibrous pericardium, the tough sac surrounding the heart.
So there's a direct anatomical link between the neck and the middle mediastinum.
A direct link. This means that a severe infection, like an abscess in the neck's visceral compartment, if it gets past that fascial wall, has a straightforward, albeit short, path right toward the heart sac.
And the deep cervical fascia, sometimes called the prevertebral fascia. This sounds like the structural muscular back wall of the neck.
This is indeed the posterior shield. It provides structural integrity. The deep cervical fascia covers the entire vertebral column and all the associated deep muscles, the scalenes, and the longus capitis and longus colli.
So it forms the floor of the posterior triangle.
It forms the natural muscular floor of the posterior triangle. And laterally, this prevertebral fascia is critical because it extends outwards and forms the axillary sheath.
The axillary sheath.
Yes, that's the connective tissue sleeve that contains the brachial plexus and the subclavian artery as they exit the neck and head toward the upper limb. Superiorly, it attaches to the base of the skull, and inferiorly, it blends with the fascia covering the superior mediastinum, just like the pretracheal fascia. This is the fascial layer a surgeon aims to stay anterior to when operating in the anterior neck to protect those spinal structures.
Lastly, the carotid sheath, which seems like a highly condensed sleeve that bundles the major neurovascular structures.
The carotid sheath isn't truly a distinct fourth layer, but rather a specialized condensation of all three deep fascia layers, the investing, pretracheal, and prevertebral fasciae that fuse around the vascular pathway.
And it surrounds those three non-negotiable vital structures.
Correct. The common carotid artery or the internal carotid artery, the internal jugular vein, and the vagus nerve.
And the organization within the sheath is always consistent.
Generally, yes. The artery, the CCA or ICA, is medial, the IJV is lateral, and the vagus nerve is tucked posteriorly between the two large vessels. Interestingly, the source notes that the sheath tends to be thicker and more fibrous around the high-pressure arteries than around the lower-pressure IJV.
And it's not a closed tube.
No, it's important to remember that this sheath isn't a completely isolated cylinder. It communicates superiorly to the base of the skull and inferiorly to the chest, allowing for some vertical spread of pathology.
Understanding these fascial layers brings us to the spaces they create, spaces that determine the path of infection and define surgical risk. Let's map out the three critical deep spaces, which are effectively anatomical tunnels.
The location of these spaces is paramount for clinical safety. The first is the retropharyngeal space, which is sometimes referred to as the posterior visceral space.
Where is that located?
This space sits immediately posterior to the pharynx and esophagus, the viscera, and anterior to the prevertebral fascia, the back wall. It contains loose connective tissue and some lymph nodes.
What's the clinical concern with the retropharyngeal space?
Infections in this space, often originating from tonsillitis or pharyngitis, create an abscess that expands forward, and it can potentially displace the pharynx forward and obstruct the airway. It's a serious pediatric emergency.
Height is limited, right?
It is typically limited. It generally extends only from the base of the skull down to the level of the lower cervical vertebrae, usually C6 or C7, and then it ends.
Then there's the prevertebral space, which contains the deep muscles.
The prevertebral space is located directly between the prevertebral fascia and the actual vertebral bodies. This space contains the prevertebral muscles, longus capitis and colli, and the roots of the spinal nerves.
And the clinical relevance there.
Clinically, it's relevant because tuberculosis of the spine, Pott's disease, can lead to cold abscesses, collections of pus that track forward within this space, sometimes presenting as a palpable mass in the posterior neck.
And now for the true aha moment of this deep dive and the entire section on fascia, the danger space. Why is it named so dramatically?
The danger space earns its name because it is the body's superhighway for transmitting catastrophic infection from the neck into the thorax.
Where is it?
It lies between the alar layer, which is a subdivision of the pretracheal fascia anteriorly, and the deep cervical or prevertebral fascia posteriorly.
So it's sandwiched between the front wall and the back wall. What makes it spread so dangerous compared to the retropharyngeal space, which is right next door?
Its danger lies entirely in its extent. Unlike the retropharyngeal space, which usually stops around C7, the danger space is structurally continuous.
It just keeps going.
It extends without interruption all the way from the base of the skull at C1 down through the entire neck and, critically, through the superior mediastinum, all the way down to the diaphragm, which can be as low as T12.
That's essentially a wide-open tunnel from your neck directly to the heart region.
Exactly. Infections that spread rapidly and extensively into the posterior mediastinum can cause life-threatening mediastinitis, an inflammation of the central chest tissues that is often fatal if not diagnosed and treated immediately.
So that one anatomical detail defines why a seemingly localized neck infection can become a major systemic emergency in a matter of hours.
It does. The fascial layers, while protective, also define the paths of greatest risk.
From the static architecture of the fascia, let's transition to the dynamic engine of the neck. The muscles, which facilitate stabilization, complex head movement, speech, and swallowing.
We begin with the most superficial muscle, the platysma. It's a broad, thin sheet of muscle found right in the superficial fascia. It originates from the skin of the deltoid and pectoral regions and attaches superiorly to the mandible and the skin below the symphysis mentae.
So it's basically a muscle of facial and neck expression.
It is. Its function seems relatively limited, but as we know from cosmetic procedures, it is hugely significant for the appearance of the neck.
What does it do?
Functionally, it acts to depress the jaw and the angle of the mouth, creating a look of tension or sadness. And crucially, its contraction produces those vertical ridges and creases in the neck skin, which can become prominent with age.
And its innervation.
Its motor innervation is provided by the cervical branch of the facial nerve, cranial nerve 7. Damage to the small nerve branch, say during a parotid gland surgery, can result in paralysis of the lower lip and surrounding neck tissues, leading to cosmetic asymmetry.
The sternocleidomastoid, the SCM, as we've established, is the undisputed landmark muscle of the neck used to define the triangles.
Absolutely. It's that obliquely running muscle forming the prominent V shape on the side of the neck. It originates with two distinct heads. The tough sternal head from the manubrium of the sternum, and the flatter clavicular head from the medial third of the clavicle.
And it runs up to the head.
It runs superiorly and posteriorly, often creating a deep groove between its two heads to insert onto the mastoid process and the lateral part of the superior nuchal line. Its oblique course is the key to its rotational function.
And its action and innervation are complex, coordinating multiple movements, including respiration.
Its primary motor innervation is supplied by the accessory nerve, cranial nerve 11. However, it receives sensory and proprioceptive fibers, telling the brain where the muscle is in space, from the ventral rami of C2, C3, and C4, which enter the muscle at multiple points.
What are its coordinated movements?
In terms of action, unilateral contraction is complex. It turns the head to the opposite side while tilting the head ipsilaterally. Think of looking over your right shoulder. Your left SCM contracts.
And might both contract.
Bilateral contraction acts primarily as a strong neck extensor when the head is already partially flexed. And when the head is fixed, the SCM powerfully helps elevate the sternum and clavicle, making it a critical accessory muscle for deep, forced inhalation.
You can see it working during respiratory distress.
You can. The muscle is also central to the pathology of congenital torticollis, or wry neck, where fibrosis causes the muscle to shorten, pulling the head into that characteristic tilt.
The hyoid bone's function depends entirely on the 8 muscles that attach to it, divided into the suprahyoid, or elevators, and the infrahyoid, the depressors. This system is a synchronized engine for the mechanics of eating and speech. Let's detail the 4 suprahyoid muscles first.
The 4 suprahyoid muscles generally elevate the hyoid and the floor of the mouth during the initial phase of swallowing, or they depress the mandible when the hyoid is fixed, allowing the mouth to open.
Let's start with the digastric.
Right. The digastric muscle has 2 bellies, anterior and posterior, connected by an intermediate tendon attached to the hyoid bone. And this is a fascinating evolutionary relic because of its dual innervation.
Dual innervation.
Yes. The anterior belly is innervated by the trigeminal nerve, V3, and the posterior belly is innervated by the facial nerve, cranial nerve 7.
That's incredible. Why is that?
This difference reflects their separate embryological origins from the first and second pharyngeal arches, respectively. Its dual actions are depressing the mandible, so opening the mouth, or elevating the hyoid bone during swallowing.
That dual innervation is a phenomenal anatomical surprise. It tells us that these muscles have been fused together in evolution, despite having different neural control centers.
It absolutely does. It reinforces that the neck is a region where evolutionary history is just laid bare.
Okay, muscle number 2.
Number 2 is the stylohyoid. This muscle runs parallel and superior to the posterior belly of the digastric. It elevates and draws the hyoid bone posteriorly, which helps lengthen the floor of the mouth. It's innervated by the facial nerve, consistent with its origin near the digastric posterior belly.
And number 3.
Number 3 is the mylohyoid. This is a broad, flat muscle that forms the entire muscular floor of the mouth. When both sides contract, they elevate the entire floor, pressing the tongue up against the palate to initiate swallowing. It's innervated by the trigeminal nerve, V3, which reflects its role in mandibular and oral cavity actions.
And the 4th suprahyoid.
The 4th is the geniohyoid. It's located superior to the mylohyoid, right near the midline. This muscle is innervated by C1 fibers, which travel by hitchhiking along the sheath of the hypoglossal nerve, cranial nerve 12.
What does it do?
Its action is to elevate and draw the hyoid bone forward, protracting the tongue complex.
That hitchhiking phenomenon, C1 fibers, using the CN12 sheath, is another brilliant piece of anatomical detail. Now for the infrahyoid group, the forestrap muscles, they generally stabilize, fix, or depress the hyoid or larynx.
The 4 infrahyoid muscles are the omohyoid, sternohyoid, sternothyroid, and thyrohyoid. They are the body's natural neck stabilizers, ensuring the hyoid and larynx return to their resting position after swallowing or speaking, and most of them are innervated by the ansa cervicalis.
Okay, let's go through them.
First, the omohyoid. This muscle has 2 bellies, superior and inferior, connected by an intermediate tendon that is deep to the SCM. Its main role is to depress, retract, and stabilize the hyoid bone, often tightening the carotid sheath in the process. Its innervation is via the ansa cervicalis, C1 to C3.
Second,
the sternohyoid. This is a long, thin muscle running from the sternum to the hyoid. It directly depresses the hyoid bone after the suprahyoids have elevated it. It's also innervated by the ansa cervicalis, C1, C2, and C3.
Third is the sternothyroid.
This muscle is broader and shorter than the sternohyoid. Its unique feature is that it depresses the larynx, but unlike the others, it does not attach to the hyoid bone. Instead, it attaches to the thyroid cartilage. It's also innervated by the ansa cervicalis.
And the last one, the thyrohyoid.
The thyrohyoid. This muscle is short and runs between the thyroid cartilage and the hyoid bone. And like the geniohyoid, it is uniquely innervated by C1 fibers via the hypoglossal nerve sheath. Its action is complex. It can either depress the hyoid or, when the hyoid is fixed by the superior group, it can elevate the larynx.
So if you want to remember the innervation pattern of the strap muscles, it's mostly the ansa cervicalis, except for the 2 that have H's in their names, geniohyoid and thyrohyoid, which get their C1 fibers via the hypoglossal nerve. That's a good mnemonic for the learner.
That's a great way to remember it.
Moving to the deepest layer, against the spine, we find the muscles responsible for stabilizing the spine and producing gross head movements. The deep vertebral muscles. They're split into the anterior and lateral groups.
The anterior vertebral group includes the rectus capitis muscles, anterior and lateralis, and the longus muscles, capitis and colli. They lie deep, right against the vertebrae. They are primarily flexors of the head and neck, stabilizing the area against the constant pull of the posterior extensor muscles.
And they're innervated by?
They're innervated by the ventral rami of the cervical spinal nerves. The longest colli muscle in particular is the longest, running across multiple vertebral segments from C1 down to T3. It acts to flex and rotate the neck, and its deep position makes it highly important in stabilizing the cervical spine.
The lateral vertebral group contains the scalenes anterior, medius, and posterior. These are incredibly important clinically due to their relationship with the neurovascular structures exiting the neck and their direct involvement in conditions like thoracic outlet syndrome.
They are arguably the most critical muscular landmark in the lower neck. All 3 scalenes are active during deep forced inhalation because their primary action is to elevate the first 2 ribs. They're all innervated by the ventral rami of the lower cervical nerves, C3 to C7.
Let's start with scalenus anterior.
The scalenus anterior, or SA, attaches to the first rib. It is the crucial divider of the subclavian artery. Remember this. The subclavian artery runs posterior to the SA, while the subclavian vein runs anterior to it.
And a major nerve runs on it.
Yes. Also, the phrenic nerve, the nerve that controls the diaphragm, runs vertically down its anterior surface. This relationship means that trauma or spasm of the SA can compress that nerve.
Then scalenus medius.
Scalenus medius, or SM, is the largest and longest scalene attaching to the first rib, lateral to the SA. And finally, the scalenus posterior, SP, is the smallest, attaching to the second rib.
You mentioned the crucial relationship to the vascular and nervous structures. This brings us back to that confined space between the anterior and middle scalenes. This is where high-pressure vessels and major nerve trunks are funneled through.
Yes, the interval between the scalenus anterior and the scalenus medius is vital, the interscalene triangle. The trunks of the brachial plexus and the subclavian artery pass directly through this interval as they exit the neck toward the upper limb.
And it's a tight squeeze.
The tight nature of this passage, bordered by muscle, the first rib, and the clavicle, means that any pathology, a tight, hypertrophied scalene muscle, or a rare bony anomaly like a cervical rib can compress that neurovascular bundle.
So pain, numbness, or tingling down the arm or discoloration in the hand could be a symptom of a muscle spasm in the neck, compressing the brachial plexus right there between the two scales.
Absolutely. That's the classic presentation of neurogenic thoracic outlet syndrome. It illustrates perfectly how the anatomy of the neck floor directly translates into limb symptoms. The SA is the defining boundary, the protector, and also the potential trap for the structures passing into the arm.
Now we enter the major highways of the neck, starting with the arterial system, the carotids, the massive conduits ensuring the brain gets its constant high-pressure blood supply.
The common carotid arteries, the CCAs, are the major source of blood to the head and neck, and their origin is asymmetrical. The right CCA arises from the brachiocephalic trunk, while the left CCA arises directly from the aortic arch.
And they run up through the neck deep to the SCM.
They run superiorly deep to the SCM, shielded within the carotid sheath, and they typically do not give off any branches in the neck.
Where does the crucial split happen? The bifurcation.
Typically, the CCA bifurcates into the internal carotid artery, the ICA, and the external carotid artery, the ECA, at the level of the upper border of the thyroid cartilage. This usually corresponds to the C3-C4 vertebral level.
And that's a good place to feel a pulse.
It is. That location, near the corner of the jaw, is where a clinician can easily palpate the carotid pulse. And the source notes that the angle of this bifurcation can change significantly with age or due to conditions like atherosclerosis, plaque buildup, which is a key concern in stroke prevention. The internal and external carotids are initially contained within the same carotid sheath.
The external carotid artery, the ECA, supplies structures external to the cranium, hence its name, and is characterized by its 8 distinct branches in the neck. Instead of just listing them, can we group them to make them easier to remember for the learner?
That's a great approach. We can group the 8 branches into 3 functional categories: anterior, medial, posterior, and terminal.
Okay, let's start with the anterior group.
The anterior group has the first 3 branches. Number 1 is the superior thyroid artery. It's the first branch, and it descends immediately to supply the thyroid gland and larynx. It runs closely with the external laryngeal nerve, making that nerve highly vulnerable during any ligation of this vessel. Number 2 is the lingual artery. It supplies the entire tongue, the hyoid, and the floor of the mouth, running deep to the hyoglossus muscle. And number 3 is the facial artery. This supplies the face and the submandibular gland, crossing over the inferior border of the mandible, where you can often feel its pulse. These 3 are often the first vessels ligated in neck dissection procedures.
And the medial branch.
The medial branch is singular. It's the ascending pharyngeal artery. It's the smallest and first medial branch, and it supplies the pharynx, prevertebral muscles, and the middle ear.
And the posterior group running backward.
Right. Number 5 is the occipital artery. It runs posteriorly to supply deep neck muscles and the scalp, passing around the posterior belly of the digastric muscle. Number 6 is the posterior auricular artery, a small branch supplying the region behind the ear and the parotid gland.
And finally, the 2 terminal branches.
The 2 terminal branches. Number 7 is the maxillary artery, which supplies deep structures of the face, the teeth, and the muscles of mastication. And number 8 is the superficial temporal artery, which continues superiorly and is often palpable, giving off branches that supply the temporal scalp.
In contrast, the internal carotid artery, the ICA, has a much simpler course in the neck, which is a major diagnostic feature.
The ICA does not give off any branches in the neck. It ascends directly, deep to the parotid gland and the styloid process, and enters the base of the skull via the carotid canal to supply the cerebrum and the eye.
So its only job in the neck is to get to the brain.
Its entire mission in the neck is simply to get to the brain, unburdened by side branches. The location of the ICA medial to the external carotid at the bifurcation is important, though it quickly becomes deeper.
While the ICA itself is branchless in the neck, the area of the CCA bifurcation houses critical sensory structures, the carotid body and sinus, which function as the body's internal autonomous regulators. This is where the body constantly monitors vital parameters.
This is truly where mechanical sensation meets biochemistry. The carotid sinus is a slight dilation located in the wall of the CCA just before or at the bifurcation. It functions purely as a baroreceptor, a mechanical pressure sensor.
So when blood pressure rises, the walls stretch.
Exactly. When blood pressure rises, the walls of the sinus stretch, increasing the firing rate of its sensory nerves.
But what happens when it fires? What's the reflex?
The signal is transmitted primarily via the glossopharyngeal nerve, CNIX, and partially by the vagus nerve back to the brainstem. This initiates the carotid sinus reflex, which immediately responds by slowing the heart rate bradycardia and dilating peripheral vessels, thus rapidly lowering blood pressure.
And this is important for preventing fainting.
It's crucial for protecting against sudden drops in cerebral blood flow. It's what is involved when people faint, syncope from sudden positional changes. Clinicians can sometimes exploit this reflex by gentle carotid massage to treat certain rapid heart rhythms.
And the carotid body, that's the chemoreceptor, monitoring blood gas composition.
The carotid body is a separate, tiny, reddish, ovoid neurovascular structure located immediately posterior to the bifurcation. It is a chemoreceptor, highly sensitive to changes in blood oxygen, carbon dioxide, and pH levels, responding most strongly to hypoxia or low O2.
And it's innervated by the same nerves.
Richly innervated by the vagus and glossopharyngeal nerves. The carotid body contains specialized cells, glomus, or type I cells. These are neuroendocrine cells that secrete neurotransmitters like dopamine and norepinephrine when O2 levels drop, stimulating the respiratory center to increase breathing rate.
And these cells can form tumors, right?
The source notes that these glomus cells have the potential to form slow-growing, highly vascular benign or malignant tumors called paragangliomas, or glomus tumors. And they are notoriously difficult to remove due to their intimate relationship with the carotid arteries and the surrounding nerves.
Moving laterally and lower in the neck, the subclavian artery is crucial because it supplies the upper limb and much of the neck and posterior cranial circulation via the vertebral artery. The key to understanding it is its division into 3 distinct parts, defined by its relationship to the scalenus anterior muscle.
That's right. And again, the origin is asymmetrical. The right SA comes from the brachiocephalic trunk. The left SA arises directly from the aorta.
Okay, let's go through the 3 parts.
The first part is medial to the scalenus anterior. This part gives off 3 major branches, crucial for neck and chest supply. The vertebral artery, the thyrocervical trunk, which supplies the thyroid and shoulder region, and the internal thoracic artery, which descends into the chest.
The second part is behind the muscle.
The second part lies directly posterior to the bulk of the scalenus anterior muscle. This part gives off the costocervical trunk, which in turn branches into the deep cervical artery, supplying deep neck muscles, and the supreme intercostal artery, supplying the first 2 intercostal spaces.
And the third part?
The third part is lateral to the scalenus anterior. This part runs through the interscalene triangle with the brachial plexus. It is generally the most accessible surgically, lying near the brachial plexus trunks, but it typically gives off no branches in the neck, or sometimes just the dorsal scapular artery.
Let's detail the vertebral artery path. It seems incredibly protected, yet potentially vulnerable within its bony path.
The vertebral artery arises from the first part of the subclavian artery, often located about 2 centimeters above the clavicle. It immediately ascends posteriorly, passing deep to the common carotid artery and IJV. Its defining characteristic is its travel through a protected bony canal.
It enters the transverse processes of the vertebrae.
It typically enters the transverse process foramen of the 6th cervical vertebra, C6. And the source notes the specific anatomical variability. It occasionally enters higher at C5 or even C7, which is a detail that matters immensely to surgeons.
It then travels all the way up.
Yes. It continues ascending, traversing the transverse foramina of C6 up to C1. After exiting C1, it curves sharply backward and then upward to enter the skull via the foramen magnum. Its twin then joins the contralateral vertebral artery to form the basilar artery supplying the brainstem and cerebellum.
So it's safe from superficial trauma.
It is, but it's highly vulnerable to internal damage from violent head rotation, hyperextension, or chiropractic manipulation, which can lead to vertebral artery dissection and immediate stroke.
The venous system of the neck is the major outflow tract for the head. The main drainage is the jugular system, led by the massive internal jugular vein, or IJV.
The IJV is the main drainage pathway for the brain and the deep face and neck structures. It begins at the jugular foramen as the continuation of the sigmoid sinus.
And it runs in the carotid sheath.
It runs vertically within the carotid sheath, lateral to the common and internal carotid arteries, and interior to the vagus nerve. It contains two important dilations, the superior bulb near the skull base and the inferior bulb near its termination.
And it joins the subclavian.
It joins the subclavian vein behind the SCM to form the brachiocephalic vein, the great vein of the upper chest.
The external jugular vein, the EJV, is much more superficial and visible under the skin.
The EJB is formed by the union of the posterior auricular vein and the posterior division of the retromandibular vein, typically superficial to the SCM. It runs inferiorly and crosses the SCM obliquely before piercing the deep cervical fascia above the clavicle to drain into the subclavian vein.
And it has valves.
The vein often features valves, though they are frequently incompetent, allowing visualization of venous pressure changes when you're lying down, a key clinical sign of heart failure.
And the anterior jugular vein, or AJV, which is notable for its midline connections and low entry point.
The AJV runs near the midline and drains the superficial structures of the anterior neck. The key feature is the formation of the jugular venous arch, where the AJV joins its contralateral partner in the suprasternal space, the space of Burns, deep to the investing fascia, right above the sternum.
And it drains into?
It ultimately drains into the external jugular or the subclavian vein. This arch must be carefully avoided during low-lying neck procedures.
Finally, the vertebral vein, running deep and accompanying the vertebral artery.
The vertebral vein accompanies the vertebral artery, passing through the same transverse foramina, though it often starts lower, around C7. It drains the deep cervical muscles and receives tributaries from the internal and external vertebral venous plexuses, which are valveless networks surrounding the spinal cord. It typically drains into the brachiocephalic vein.
Moving to the control center, the nerves of the neck are perhaps the most functionally vital and surgically vulnerable structures. We start with the cervical plexus, the network formed by the upper spinal nerves.
The cervical plexus is formed by the ventral rami of the upper four cervical nerves, C1 to C4, which link up to form loops. It sits deep to the SCM and is responsible for motor innervation to many neck muscles, as well as providing sensory innervation to large areas of the head, neck, and chest skin.
And the branches are divided into superficial and deep.
Two main categories: superficial, which are sensory, and deep, which are motor.
The four superficial sensory branches are easily identifiable, all emerging at the same location. The posterior border of the SCM, a critical surgical landmark known as Erb's point or the nerve point.
Precisely. If you administer anesthesia to this point, you block sensation across the entire lateral neck.
Yeah.
They radiate outward to supply the skin.
Let's list them.
First, the lesser occipital nerve, C2. It ascends to supply the skin behind the ear and the upper posterior scalp. Second, the great auricular nerve, C2 and C3. It rises vertically, supplying the skin over the parotid gland, the auricle or outer ear, and the area covering the angle of the mandible.
And that one is frequently damaged.
It is the one most frequently compromised during surgical procedures like lymph node biopsies or facelifts in this area, potentially leading to permanent numbness.
Okay, the last two.
The third is the transverse cervical nerve, C2 and C3. It crosses the SCM horizontally, supplying the skin over the anterior triangle of the neck. And fourth, the supraclavicular nerves, C3 and C4. These descend as medial, intermediate, and lateral branches, supplying the skin over the shoulder and upper chest, overlapping the area supplied by the second thoracic nerve, T2.
The deep motor branches are crucial for movement and crucially for survival functions like breathing.
The most notable deep motor branches are the ansa cervicalis and the phrenic nerve. The ansa cervicalis is the critical nerve loop that powers our infrahyoid strap muscles. It's formed by a superior root from C1 and C2 and an inferior root from C2 and C3.
And it supplies?
This loop supplies the sternohyoid, the sternothyroid, and the omohyoid. Damage to this loop results in difficulty depressing the hyoid and stabilizing the larynx, impacting the efficiency of the later stages of swallowing.
And then the phrenic nerve.
And the phrenic nerve.
Yeah.
C3, C4, C5 keeps the diaphragm alive. It is absolutely essential for respiration, providing the sole motor supply to the diaphragm, and it runs vertically down the anterior surface of the scalenus anterior muscle.
Wait, if it runs on the anterior surface of the scalenus anterior, it is right next to the subclavian vein in the root of the neck and deep to the SCM.
That's right. Its path makes it highly vulnerable to injury during procedures around the subclavian vein, like central line placement or lower neck surgery. Accidental cutting or crushing of the phrenic nerve leads to paralysis of the ipsilateral half of the diaphragm, severely compromising respiratory capacity, especially in already compromised patients.
3 cranial nerves are prominent in the neck, passing through to perform complex sensory and motor functions. CNIX, the glossopharyngeal, CNX, the vagus, and CNA usteri, the accessory.
The glossopharyngeal nerve, CNIX, descends deep to the stylohyoid muscle. Its branches in the neck are primarily involved in sensation for the pharynx, the parotid gland, and the posterior third of the tongue. And critically, it gives off the carotid sinus nerve, which is the primary sensory input for the baroreceptors of the carotid sinus, as we established earlier.
The vagus nerve, CNX, is the major parasympathetic regulator, running right through the carotid sheath, connecting the brain to the heart, lungs, and gut.
The vagus nerve runs vertically within the carotid sheath, nestled tightly between the IJV and the common carotid artery, making it unavoidable in any procedure addressing the great vessels. And it gives off two extremely important laryngeal branches high in the neck, the superior laryngeal nerve and the recurrent laryngeal nerve.
Let's take the superior laryngeal nerve first.
The superior laryngeal nerve, or SLN, branches off the vagus high in the neck and immediately splits. It splits into the internal laryngeal nerve, which is purely sensory, supplying the mucosa above the vocal cords, and the external laryngeal nerve, or ELN, which is purely motor, supplying the cricothyroid muscle.
Why is the ELN so vulnerable, and what is the consequence of injuring it?
The ELN runs perilously close to the superior thyroid artery. It must be identified and preserved during ligation of the superior thyroid artery. The consequence of injury is unique. Paralysis of the cricothyroid muscle means the vocal cord cannot be tensed.
So it affects your voice pitch.
Since the cricothyroid is the primary pitch tensor, injury results in the inability to produce high-pitched sounds or project the voice strongly. It's often noticed by singers or public speakers.
Now, the recurrent laryngeal nerve, the RLN, is perhaps the most famous nerve in thyroid surgery.
It is. It supplies motor innervation to all other intrinsic laryngeal muscles, controlling the adduction and abduction, the opening and closing of the vocal cords, and its course is complex and asymmetrical.
The course difference based on side is phenomenal and important to memorize.
Indeed. The left RLN loops far down under the arch of the aorta in the chest, while the right RLN loops under the subclavian artery in the root of the neck.
Then they both ascend.
Both nerves then ascend vertically, running in the groove between the trachea and the esophagus, the tracheoesophageal groove. Their close proximity to the posterior surface of the thyroid gland, sometimes embedded within the gland's capsule, makes them the single most common major nerve injury in thyroid surgery.
Resulting
in vocal cord paralysis and persistent hoarseness or difficulty breathing due to cord malposition.
And finally, the accessory nerve, CNXY, which we noted crossing the posterior triangle.
The accessory nerve provides motor supply to the large stabilizing muscles, the SCM and the trapezius. It runs obliquely across the posterior triangle, often very superficially, right beneath the investing fascia.
Which makes it acutely vulnerable.
Acutely vulnerable to accidental injury during lymph node biopsy or surgical procedures like neck dissections in that region, leading to a classic presentation of shoulder drooping paralysis of the trapezius and difficulty raising the arm above the horizontal.
Deep within the neck, lying against the prevertebral fascia, we find the sympathetic trunk, responsible for our involuntary fight-or-flight control systems for the head and face.
The cervical sympathetic trunk lies deep, medial to the vagus nerve and the carotid sheath, running parallel to the vertebral column. It consists primarily of 3 ganglia, which act as relay stations, receiving preganglionic fibers from the thoracic spinal cord, T1 and T2, and sending postganglionic fibers up to the head and neck.
Detail those 3 ganglia and their key relationships.
First is the superior cervical ganglion, the SCG. This is the largest, typically located at the C1-C2 level. It is the crucial source of sympathetic fibers to the head, controlling pupillary dilation, eyelid elevation, and facial sweating. It wraps around the internal carotid artery and also gives off cardiac and superior thyroid branches.
And the middle one?
Second is the middle cervical ganglion, or MCG. This is the smallest and most variable, located at the C6 level, usually near the inferior thyroid artery. It contributes cardiac and thyroid branches.
And the lowest one?
Third is the inferior cervical ganglion, or ICG, which is also called the stellate ganglion. This is formed by the fusion of the inferior cervical ganglion and the first thoracic ganglia, usually located at the C7 level, right at the root of the neck. It lies immediately anterior to the neck of the first rib, intimately related to the subclavian artery and the beginning of the vertebral artery. It is the major pathway for sympathetic innervation to the upper limb, head, and heart.
The clinical connection here is critical. Damage to this trunk, particularly in the lower neck near the stellate ganglion, causes a distinct classic syndrome.
Damage to the sympathetic trunk, or the sympathetic fibers as they ascend through the neck, for example, caused by tumors in the apex of the lung, trauma, or improper surgical block results in Horner syndrome. This is a loss of sympathetic tone to the head and neck.
Which results in the classic triad.
It results in the classic triad. 1. Ptosis, which is drooping of the upper eyelid due to paralysis of the superior tarsal muscle, which normally holds the lid slightly elevated. 2. Miosis, which is a constricted pupil due to paralysis of the dilator pupillae muscle, which normally makes a pupil wide. And 3. Anhidrosis, a lack of sweating on the affected side of the face and neck.
That one small nerve chain controls so much. The elegance of anatomy often reveals itself most clearly in the consequences of its disruption.
Absolutely.
Finally, we reach the deep visceral compartment located within the pretracheal fascia, the glands responsible for hormonal regulation, and the pathways for air and food.
The thyroid is a highly vascular endocrine gland located low in the neck, deep to the infrahyoid muscles. It wraps around the trachea and larynx, typically extending from the C5 to T1 vertebra levels. It averages about 25 grams in weight, but is highly variable in size, which is important for evaluating thyroid disorders, such as goiters.
Describe its structure and location relative to the airway.
The thyroid consists of two large lobes, a right and a left, connected by a central bridge called the isthmus, which usually crosses the second, third, and fourth tracheal rings. It's important to note the histology. It's composed of thousands of follicles containing colloid, where T3 and T4 hormones, thyroxine, are produced by the follicular cells, regulating the body's entire metabolism.
What about its remarkable blood supply? It requires a massive inflow to regulate metabolism effectively.
The gland is incredibly vascular. It's often considered a highly managed arteriovenous malformation. Its primary arterial supply comes from two major sources: the superior thyroid artery, the first branch of the ECA, and the inferior thyroid artery, the largest branch of the thyrocervical trunk, which comes from the subclavian.
And they connect.
These two vessels form extensive and necessary anastomoses within the gland. The venous drainage is managed by three pairs of veins: the superior and middle thyroid veins, which drain into the IJV, and the inferior thyroid veins, which drain directly into the brachiocephalic veins.
And we must revisit the key neurovascular relationship here, given the surgical risk. Which arteries correspond to which nerve risk?
This is the high-stakes dance of thyroid surgery. The recurrent laryngeal nerve runs immediately posterior to the thyroid gland, often intimately related to the final branches of the inferior thyroid artery. It must be identified and preserved during a thyroidectomy to avoid vocal cord paralysis.
And the superior artery?
The superior thyroid artery runs closely with the external laryngeal nerve. Therefore, careful ligation of the superior thyroid artery poles is necessary to protect the ELN and prevent loss of vocal pitch control.
Deep to the thyroid, we find the parathyroid glands, the body's tiny but powerful regulators of calcium and phosphate homeostasis.
There are typically 4 small, yellowish-brown parathyroid glands situated on the posterior surface of the thyroid capsule. They are often embedded within the thyroid tissue itself, making them difficult to locate surgically. They're typically only 3 to 6 millimeters long.
And their location varies.
It does. The superior pair is generally more constant in location, near the level of the cricoid cartilage at C6. The inferior pair is highly variable in location because they migrate during development alongside the thymus gland.
So they can be found anywhere.
They can be found anywhere from the angle of the jaw down into the chest, into the mediastinum, but are often closely associated with the inferior thyroid artery due to their shared blood supply.
What is their primary function on a cellular level?
The main cell type is the chief cell, which secretes parathyroid hormone, or PTH. PTH is essential for calcium homeostasis, acting on the bones, kidneys, and gut. The other type is the oxyphil cell, which is larger and increases in number with age. Their function isn't fully understood.
And their blood supply?
They are predominantly supplied by the inferior thyroid arteries. Their small size, delicate function, and highly variable location are why parathyroid surgery requires precise preoperative imaging and meticulous surgical technique to ensure their preservation.
Finally, the core passageways of the neck. The esophagus and the trachea confined within the visceral compartment.
The esophagus, or esophagus, is a muscular tube about 25 centimeters long. The cervical portion begins at the level of the 6th cervical vertebra, C6, continuous with the pharynx. It runs vertically down the neck, located immediately posterior to the trachea. It's medial to the common carotid arteries, tucked against the vertebral column. Its posterior location and muscular walls define that tracheoesophageal groove where the RLN ascends.
And the trachea, the cervical portion of the airway.
The cervical portion of the trachea extends from the larynx at C6 to its bifurcation in the thorax at T5. It is formed of C-shaped cartilaginous rings, which are incomplete posteriorly, allowing the esophagus to expand anteriorly when swallowing large food masses. It is flexible and highly mobile.
And the sources highlight a crucial clinical distinction here.
They do. The adult trachea is about 1.25 centimeters in diameter in males, but children have significantly smaller tracheal diameters, often less than a millimeter until about age 6. This minute difference makes children dramatically more vulnerable to rapid airway obstruction from swelling or foreign bodies.
How is this deep visceral compartment vascularized?
The upper trachea and the esophagus receive their blood supply primarily from branches of the inferior thyroid arteries and the inferior laryngeal arteries. Venous drainage occurs through the inferior thyroid veins and paratracheal vessels. These structures are all confined within the pretracheal fascia, the protective layer that separates them from the carotid sheath laterally and the vertebral column posteriorly.
Okay, that's a lot to cover.
To synthesize what we've covered in this deep dive, the neck is a masterpiece of compact multi-layered engineering. Its complexity, from the dual innervation of the digastric muscle to the asymmetrical looping path of the recurrent laryngeal nerve, requires a highly ordered spatial organization.
And the takeaway for the learner?
The key takeaway for you, the learner, is that the fascial planes and the triangles are not just academic concepts. They are the crucial anatomical maps that dictate life and death in a clinical setting.
Exactly. Understanding the fascial planes, especially the distinction between the retropharyngeal space and the danger space, is the true aha moment for understanding how a simple localized infection can become a fatal, rapidly spreading case of mediastinitis.
We've charted the most crucial routes, from the superficial platysma wrinkles to the deep sympathetic ganglia that control your pupil size.
And this detailed knowledge provides a critical filter for understanding clinical issues, especially where the neurovasculature is vulnerable to compression or surgical trauma.
We've identified the points of highest risk: the path of the accessory nerve across the posterior triangle, the path of the external laryngeal nerve near the superior thyroid artery, and the tight squeeze of the brachial plexus between the scalenes.
So what does this all mean? It means the neck is constantly balancing life and death, breath and blood flow, silence and speech. Consider the critical, moment-by-moment regulation of the carotid body and sinus. This minute structure in your neck is sensing your blood gas composition and pressure, ensuring your brain remains perfused and oxygenated.
And all of this autonomous control is regulated by tiny, vulnerable sympathetic chains and delicate cranial nerves.
So if even one of those systems is compromised, say minor trauma affecting the sympathetic trunk, you get the distinct systemic consequence of Horner syndrome: pitosis, meiosis, and anhidrosis.
It is a perfect, tangible example of a microscopic anatomical lesion leading to a systemic neurological deficit that affects the entire side of your head.
It makes you appreciate the engineering even more. The next time you encounter information about neck surgery, whether it's a carotid stent or a thyroidectomy, remember the intricate dance happening deep inside, and perhaps explore the modern surgical approaches that specifically target minimizing trauma to those delicate nerves like the vagus and the recurrent laryngeal nerve.
That balance between necessary access and preserving function, between the scalene muscles and the brachial plexus, between the carotid artery and a glomus tumor, that defines surgical innovation in this area and is always worth exploring further.